Well, it's a pleasure to be here at BAUS again, this time in Manchester, and to talk about something I always enjoy talking about, chronic pelvic pain. Now, it turns out that on Thursday, I will be presenting a talk on understanding bladder pain, and it's going to start right off where you left off, of how to actually understand bladder pain in 2015 and how to effectively and truly effectively manage patients who present with what we called interstitial cystitis bladder pain syndrome. But today, we're going to talk about pelvic pain in men. And many of the lessons that we have learned from our chronic prostatitis clinic, which has been going on for 25 years in Kingston, we have used when we cross the hall to my bladder pain syndrome clinic. So, you know, some of the things are equivalent. Some disclosures: I work with almost every company that has anything to do with chronic pelvic pain in men. And we're going to start right off one message. If you only can think of one thing when you walk out of here, think of the snowflake hypothesis. And I do believe in the UK you get snow once in a while. And the snowflake hypothesis is that every man, although they present with similar type of clinical symptoms, actually are individuals and are very unique. And we have to evaluate them that way and treat them that way with an individualized, what we call phenotypic specific treatment. The first lesson is that term we call prostatitis is not just inflammation and infection. It was so easy when I was a resident, and I was told that all the pain in men was secondary to the prostate, and it was secondary to inflammation. Of course, we've known from time of Lister that inflammation is caused by infection, so we could easily diagnose it, we could easily treat it with antibiotics and anti-inflammatories. But we know that it's more complicated than this. Actually, this is a whole 1-hour lecture that I presented at a meeting just outside, affiliated with the AUA in New Orleans, on what causes CPPS in men, and I have a similar one in females as well. But to paraphrase what's actually going on here, something happens to initiate it, either an infection, a trauma, dysfunctional voiding in an anatomical, genetic, or physiologically or immunologically susceptible individual. And then through various immunological, neurological, and neuromuscular type of mechanisms, it's propagated. So not everybody with an infection in the prostate or bladder, or a sexually transmitted disease, or somebody who injures their perineum or ineffectively voids are going to end up with chronic pelvic pain. But for some reason, some patients do. And we're starting to look into the genetics and the immunology and the neuropathies that are associated with this. The second is that this is a very prevalent and important disease or condition, and has a significant impact. Anybody that practices urology in general practice understands this. About 8% of men at any one time have prostatitis-like symptoms, and a third of those actually complain about it to their family physician or urologist because it impacts on their life. And it's not just a Western disease, as we once thought. It wasn't something we just invented because medical therapy took many of the TERPs away from us. It's just as common in places as Africa, Asia, Australia. In fact, it's even more prevalent in Finland and Italy and Mexico and China than it is in North America or Western Europe. And the impact, when these patients have it, the impact financially on society is more than a patient who has insulin-dependent diabetes. As far as the patient and its impact on activities and his quality of life, it is more impactful than if a patient just had an acute myocardial infarction, a patient with active Crohn's disease, a patient with congestive heart failure. This affects a patient's quality of life and activities just as much. So, if it's not just inflammation and infection, antibiotics and anti-inflammatories are not enough. I'm not going to present the data to substantiate that, but you know that. Otherwise, we wouldn't be having this whole session today on looking at chronic pelvic pain. What's interesting, and I will show you just a little tiny bit of data, is that antibiotics and anti-inflammatories do actually help some patients, and that just complicates the whole thing. So this is the lesson. That's what I mean, that snowflake hypothesis is we have to phenotype our patients. Now we can categorize them or classify them, and what we're really talking about is this category 3, chronic prostatitis, chronic pelvic pain syndrome, what we used to call non-bacterial prostatitis and prostatidynia. And we can divide it that way into inflammatory and non-inflammatory, and I do in my clinic. But if I was in private practice trying to earn a living, I wouldn't differentiate it because we've never been able to figure out a way to target treatment of whether or not there's inflammation in the prostate at all. So what I'm looking more at is the clinical picture, the phenotypes, because unfortunately we do not have an MRI finding that distinguishes these patients. We don't have a PSA, a urine test, a blood test, nothing that really helps us. So we have to go back and be old-time clinicians and be able to figure out who these patients are and how we're going to help them by using our clinical acumen, experience, and yes, even some scientific evidence. Now this is the phenotyping that we use in our institution. We're trying to say it works, but you don't have to use it. But it differentiates the patients in the 6 most important domains that is associated with a life of chronic pelvic pain. And that's urinary symptoms, psychosocial impact, organ centricity. In other words, some patients with prostatitis actually do have a prostate problem. Infection, and yes, a certain percentage of patients have either had an infection, having an infection, or respond to antibiotics. And many patients have neurogenic or systemic problems, neuropathic pain that's beyond the pelvis, and tenderness, and by that I mean pelvic floor dysfunctional pain. And then of course there's sexual dysfunction. That's why sometimes we put a little S on that, U points, or we think of sexual dysfunction as the penis and put that as an organ-centric. Doesn't really matter how you do it, but you've got to think of all these concepts. And the 2015 approach is just that. Don't worry about this slide because you can already do it in clinical. You can figure out who has urinary problems, who has a prostate problem. You just touch the prostate and you're pulling the patient off the roof. They're in such pain. And pelvic floor dysfunctional pain, you just start to do your digital rectal examination and the whole pelvis and perineum goes into spasm. Infection is easy because you just culture something or they have a history of infection. The neuropathic, well, those patients usually have pain outside the pelvis, pain in their back, pain running down their leg, irritable bowel syndrome, migraines, all these other things that can tell you that that's the case. The psychosocial, that's not very difficult. Those are the patients who are depressed, anxious, having trouble coping with stress, having trouble coping with the pain, catastrophizing. In other words, they're ruminating too much about their symptoms. They're magnifying their symptoms and perhaps even got to the 3rd stage of catastrophizing, which is the helplessness stage. So we can do that in clinic, and we can do it with a very practical way that doesn't take a long time. The history, I never take a history from one of these patients until they have completed that down the 3rd row, the CPSI, the Chronic Prostatitis Symptom Index. By filling out this form, the patient tells me where his pain is, how frequent it is, how severe it is, his storage and voiding urinary symptoms, the impact on his quality of life and activities and how much time he thinks about this. That's the information I need when I walk in and take his history. And the history is also easy because we have a little history form. He checks that out. So my whole evaluation can take the same amount of time as it does to evaluate lower urinary tract symptoms in men with BPH. It takes no longer than that if I do it this rigorous way of as soon as I find out what the patient is in for, I quickly leave the room, give him the 2 forms, come back 5 or 10 minutes later, and I have all the information I need. I do have a focus questionnaire that we're developing that helps pick out depression, catastrophizing, abuse, the associated conditions I'm looking for. At most, you have to have a urinalysis, and what I would really say you should do is a post-prostatic massage urine culture. It is so important to do that, particularly if the patient's been off antibiotics. You get a midstream, and then after the DRE, you bring the patient to his knees and tears to his eyes and do a proper prostate massage, which I could give a 5 minute lecture on, but I would refer you more to the papers produced before the First World War from the Royal Swedish Institute of Prostate Massage in Stockholm, where instead of doing fellowships, we used to visit, to spend a week or two to learn how to do a proper prostate massage. But basically, just push on prostate a little bit, and when the patient can stand up, the first voided urine, send away with that for culture. The cystoscopy, the urodynamics, the psychosocial evaluation, all of those are optional. Many patients require them. Everybody needs the urologic psychosocial evaluation at the first initiation, but a full psychological evaluation is only needed in a third of the patients. So when you do U-point, you find out that only 1 patient in 5 has only a prostate problem. 80% have other problems, psychosocial, about a third of them. Infection, usually about 20% have about a history of infection. Neurogenic or systemic problems, neuropathy, about a third of the patients. And 50% of the patients have dysfunctional pelvic floor pain. Treating the prostate gland is only going to improve the patients, 20% of the patients, 1 in 5 is going to walk out happy if your treatment is 100% successful, which they never are. So that's why we have such a dismal problem with this. But how are we going to do it? We have our traditional therapies. Do they work? Well, we did a network meta-analysis. This is a different type of net analysis. It's where we put all the clinical trials that had randomized, placebo-controlled design. They all had a similar outcome, was the CPSI or responder sub-analyses, and we pretended that they were all in one clinical trial, comparing one to another. So in fact, we can actually compare antibiotics to anti-inflammatories without them ever being tested in a clinical trial. This is accepted as now an acceptable methodology. It's helpful. You can't really use it in clinical practice, but what it lets us see is whether these traditional therapies that we have work. So we end up with a nightmare scenario of this, that they actually published for me in JAMA, and I received a lot of comments about this, how to interpret it. When I first looked at it, the statistician actually presented this to me in 3D, and then he had it on the computer rotating around and said, "Isn't that cool, Dr. Nickel?" I still don't understand it in 3D, much less 2D, but actually what it does is it allows us to compare every treatment with another on the treatment effect, the difference between what the patients on treatment had versus what they had on placebo, or what the difference they had in the other treatment, like antibiotics versus anti-inflammatories. And I won't go into this because it was a nightmare for me and I lost sleep over it, but all of a sudden you see that some of the treatments actually work. And we tried to simplify it by looking at responder analyses, how many patients actually got better, had a clinically significant response. Boy, I see a lot of glazed eyes out there, and mine were too, because what I'm going to do is interpret this for you. And interpreting it is what we found out, that all our treatments that we use, when you lump them all together in this single huge clinical trial with over 2,000 patients, clinical trial, of course, that never existed, we actually saw that all these treatments do work in a statistically significant way. However, we had a huge disconnect between the benefit in the entire population and the individual responses. In other words, some patients got very much better on these treatments, but it only made a dent in the overall population. So what have we learned? We've learned that the traditional medical therapies can work, but monotherapy is not very effective. So we believe in our last lesson is that phenotypically directed therapy will likely be the key to treatment success. So each one of these domains, we know we have effective treatment for urinary symptoms, for prostate problems, for infection, for pelvic floor functional pain, and yes, even for the psychological problems that many of these patients have in terms of coping and depression. So we have treatments for each one of these domains that's evidence-based or best evidence-based, and what we do is we try and define the patient in what phenotypes they have and direct therapy. Now, I don't have time to really discuss this at much length in 15 or 20 minutes, but let me tell you, we did this early on, about 5 years ago, in the first 100 patients that we had. We defined their phenotypes, and many patients had 2, 3, 4, and even 5 or 6 different phenotypes, and we treated according to that algorithm, so it'd be a multimodal, therapeutic, phenotypically directed, individualized based therapy. Wow. In other words, every patient had a different therapeutic plan when they walked out of the office. We followed them up for 6 months. And our success rate from when we were doing monotherapies went up from 35 to 38% up to 84%. That means 4 out of 5 patients not only had a significant improvement or a perceptible improvement, which is a 3-point fall, they had a 6-point fall. In other words, we had clinical success in 4 out of 5 patients. And we set realistic goals for these patients, a 3-point improvement or that they felt they were moderately or markedly better. That was our goal. We tried some activities. And we had in 4 out of 5 patients, we achieved that realistic goal. And the overall population, we had a very significant decrease in CPSI. And what's important, on the right, you'll see the total score. That's a massive decrease in total score, one you do not see in clinical practice in a population. But we saw that in the pain domain of the CPSI, the voiding domain of the urinary domain of the CPSI, and also the impact and quality of life. By addressing all the domains, we took care of the urinary, the pain, and the quality of life, and that's why we got the improvement. We've now done this in 500 patients, and our prostatitis clinic, which we now, of course, call male chronic pelvic pain clinic, is a happy place. It used to be a very depressing place. Nurses don't mind working there. The residents don't mind coming now, and the patients leave 4 out of 5 very satisfied. Even the 1 out of 5 that isn't usually leaves our clinic feeling better about the disease and what we're doing because he understands what we're doing with the patient. The future, well, MAP is something we're just finishing up. We hope to have some biomarkers that help us better phenotype patient-direct therapy. We just started MAP2, which is a 5-year project to look at symptoms, and this is a very aggressive program that we're going to spend $50 million comparing these phenotypes, the microbiome of the gut, and in women, the vagina, and the prostate and bladder. We're going to look at the biomarkers, inflammatory biomarkers specifically, and all the patients are getting functional MRIs. We're incorporating an ATLAS study so that we do another baseline and follow-up every time treatment is changed, up to 3 times over 3 years. So they could get up to 5 functional MRIs, looking at what is actually happening in the central nervous system according to biomarkers, phenotypes, and changes in the microbiome. What we're going to start in 5 years is called the MIP study, which is going to be the multiple interventions for pelvic pain syndrome, our study, and that is the one where we're going to actually validate what I just talked about today. So the final lesson is we can actually successfully manage chronic pelvic pain. It is a pleasure to take care of these patients. They're easier to deal with now than male LUTs, which you all know how to deal with. And we continue to use our classical therapies, but we use them in a much better better way by phenotyping our patient and producing an individualized, phenotypically directed therapeutic plan for every patient. That strategy actually works, and we hope over the next couple of years to fix that up by having the PSA for prostatitis, or at least a biomarker from the urine or blood, or some sort of functional radiological or other investigation that will better help us direct our therapy. For now, you have to put on your clinician's hat, and urologist, as a clinician, works well in this particular disease. Thank you very much, Mr. Chairman.